Good afternoon and welcome back to another edition of This Week in Digital Health. We are joined today by Dr. Dominic Pimenta and Chris Tam of Tortus. Hey guys, what's going on?
All right. Well, thanks very much for having us. Yeah. I know it's really early there and it's pretty late here, so maybe more thanks to you than thanks to us.
So, Dom, you have a funny accent. Where are you?
We are in, I was going to say sunny London then, but it's actually been raining all day. So as you'd expect, pretty rainy London.
I was going to say, has anyone ever said sunny London?
I don't think they have.
Yeah, that's just a description for London. Give me a little bit of your respective backgrounds.
Yeah, sure. I'll go first. So I'm Dom, with Dominic Pimenta. I'm a doctor. I've been clinically practicing for 16 years. I was a cardiologist for 10 years in the NHS, and then I was a pharmaceutical physician. And then the last 18 months, I worked in AI health tech research. And then I decided that I quite like health tech and I really see the potential to have huge impact on patient lives. And so decided to start my own company and then came to this accelerator we have in the UK called Entrepreneur First. And that's where I met Chris.
Chris?
Yeah, so I'm Chris. I'm a machine learning engineer and research scientist. I did some academic research in machine learning, especially machine learning for healthcare as well, and also founded two applied AI companies, and now working with Dom.
All right, so we have a serial entrepreneur and a doctor. It sounds like a good combination, right?
Yeah, I think so.
And so, why is AI important to the doctor-patient relationship?
Well, that's a pretty interesting question. So I think for lots of reasons that the patient-doctor relationship, and interestingly on both sides of the Atlantic, is really struggling right now. So we have a massive sort of long-term problem, which is in the developed world, an aging population, health inflation, so a greater number of people with a greater number of complexity. 1 in 3 adults in the world now has a chronic condition. 70% of US adults take at least one prescription medicine. So there's a huge amount of demand. And then on the clinician side, supply is really struggling. So we haven't kept up with resources. In the UK and the US for different reasons, healthcare systems are really struggling under the load. And we don't really have any good solutions to either of those problems. Like there's no more human resources that we can readily rustle up. And we certainly can't stop aging populations. We can do a bit more with preventive health, but we won't see those advantages for 20 years. So what do we do right now? So technology has to be the only answer. And I think the subacute problem here has been COVID. It's exacerbated all of that, waiting lists, access to healthcare, but interestingly also massively accelerated digital adoption. So we saw in both sides of the Atlantic again, digital adoption, telemedicine, telecare becoming a solution to the pandemic and the lockdown. Lots of problems with that maybe coming out of the back of that now, trying to restore the balance. But how do we actually redress either of those problems? Well, the new technologies that are coming down the line, artificial intelligence, looking at some of the large language models and looking at some of the like superpowered computing that is becoming more and more commercially accessible, that has to be at least part of the solution of how we can sort of redress the balance. And that works both for patients and for doctors. And that's why we think that we are optimally positioned, let's say, to build such a company.
And so the question was, though, is what does AI add to that equation? So I understand that, there's a problem, we need a solution, but how does AI resolve, a supply and demand problem?
Yeah, I mean, that's so on the, well, two sides. So our thesis is basically that AI can support clinicians to be better clinicians and support patients to be better patients. And we'll come back to both of those things. So on the clinician side, well, for example, 60% of the workload of doctors right now is basically working inside electronic healthcare record systems, doing clerical work, doing administrative work. So could you use artificial intelligence to basically remove as much of that as possible, ideally all of it, from speaking from personal experience, ideally all of it, and go back to practicing medicine face-to-face, making the availability of doctors to be doctors, increasing their capacity just by basically taking away the time that they spend basically not being doctors. And that, I think, has huge potential, and I think certainly has huge benefits, especially physicians like myself. And then on the patient side, we have very complex patients with very little access to specialists, with very little peer-to-peer support and very little self-management. And artificial intelligence can be a really powerful medical education tool, patient support tool, preventative health tool, and ultimately, and I'd like to see this in the future, a very powerful digital therapeutic as well. So AI could potentially help you lose weight, or help you control your blood sugar, or help you exercise. And I think those are the kind of avenues where you could optimize both the patient and the physician, and then optimize the relationship between the two ultimately.
So you mentioned patient education. How is AI going to be better than Dr. Google?
That's a good question. I think, Chris, I don't know if you want to have a think about that.
I mean, it's more like scalable. You can give everyone one, and you know the cost of having an AI healthcare assistant in your phone is going to be a lot cheaper than giving everyone a doctor to explain all of the medical conditions that they have, right?
Yeah,
So
I mean,
what
what I'm suggesting is, you know, with Google, there's a tremendous amount of information and misinformation out there, right? So what we, you know, as healthcare practitioners, we don't have control over which information they're looking at, and therefore, you know, I'm sure the most dreaded thing that a doctor hears is, "I read on Google," right? You know, when they enter the office, right? So one would hope that AI would be able to sort through what is available information-wise and present information that is better suited for what they have versus, you know, what they've, you know, found online.
I mean, exactly. Like search engines haven't really changed very much in the last decade or so. You kind of have to have an idea about what you're looking for, and the search engine is like your interface to the internet, right? And very often you find people just like these search engines affirming confirmation biases that they might have. So, you know, if I Google like, is beetroot good for you, then I'm just gonna get like 10 web pages like telling me that beetroot is like the best food in the world. But equivalently, I can Google, is beetroot bad for you, and I'll get 10 pages saying beetroot is like the worst thing to eat. And it's like the same thing with coming to search engines today with your medical problem, is that, you know, there's like a whole swath of like often very contradicting information. So in terms of patient education, what the next generation of search I think will look like is putting AI in between search and the user, so that it can really filter out all this contradictions and present the patient what they need in a form that they can understand.
Mm-hmm.
And then will the clinician teach AI which is the correct information to present?
Yeah, I would. I mean, I think what's pretty interesting is like if you look at some, and there's a fair few sort of physician assistant AI is coming onto the market. I think Julie is something I've seen recently coming out in the US, and I think that potentially has hugely powerful. So it's like basically trying to distill correct information into an accessible source that then you can reinforce learn with an actual clinician on the back end to create a resource which actually is reliable, scalable, repeatable, and as sort of Chris intimated, also translatable, which means that you could have potentially the same information coming out and updated as well. And I think what's also super interesting is not just translating to other language, but basically translating from scientific language straight into plain language without having to have an intermediary explain it to you. And I think we haven't really realized how powerful that is. Suddenly, modern science, modern breakthroughs are potentially explainable to everybody without an intermediary. And I think, I don't know what that future will look like in terms of how we harness that for patients, but it will certainly be a lot more powerful than patients bringing me studies which they haven't understood because they picked out X, Y, and Z words. Whereas at least you can have a two-way communication with artificial intelligence at the level and in your own language. And I think that potentially could be hugely game-changing, especially on this, on this subject.
I mean, what's interesting is you sort of mentioned that you're looking to aggregate a lot of the functions that we are starting to see in the market, but in different formats, right? So there are, folks that are working on the administrative piece so that, we can do virtual check-ins, take you through a decision tree to help you get to the right person without spending a tremendous amount of time, and administrative costs doing your intake. So we're looking at virtual intakes as one piece. Obviously, the information is another piece. And then, I think you also alluded to compliance, right? Because you said, lose weight, right? So those are all like the digital therapeutics that remind you, like, oh, did you go for your walk today? Did you take your pill? Those types of things. Do you think that it's important to aggregate these into a single platform? Because currently we're seeing them, but they're disparate and they're all over the place.
And I think, disparate and all over the place is a pretty good description of healthcare in general.
Yeah.
But it's a really good description of where health tech is and has been for the last 20 years. And I think, as a physician, maybe I'll, interested to see what Chris thinks from a technology perspective, but as a physician perspective, it makes next to no sense, right? If you have an app for your diabetes and you have an app for your heart failure and you have an app for smoking, that's great. But most patients have all three of those things. So which app do they use? And that's never mind like the whole problem with the lack of evidence in digital therapeutics anyway. So it's not even a question of like, which of those three apps do you use? It's actually,
but that's healthcare. But what you just described, if you took it off the app, you just described healthcare, right? Because you have a cardiologist, you have an oncologist, right? And the oncologist will focus on cancer, the cardiologist will focus on your heart, and very rarely do we have this view holistic that says, oh, maybe you should consider that he's also talking to an oncologist.
Yeah, but I think maybe that's why the model's grown up in terms of apps. But actually, the difference between those two is that healthcare is supposed to be holistic. So you do have a family physician, you do have a primary care physician. Your oncologist can speak to your cardiologist, but your heart failure app cannot speak to your diabetes app. And the services that run behind a lot of these technology apps, they're not healthcare providers; they're technology providers. And I think that's a real problem in health tech. There's not enough healthcare doing good technology and a lot of technology doing healthcare. And from my perspective, anyway, I think that's what has led to this sort of slightly chaotic system that we're currently experiencing. I don't know. What do you think?
Yeah, I think it's almost like a type of market failure. And that's not a comment on my stance on the position between like public and privatized healthcare, but in the sense that, in efforts to digitize medicine, all these EHR systems were introduced, but that ironically sort of like in many cases double clinical workflow times and workloads. And it also became extremely fragmented. I think there are like 50 different EHR
in the
systems
UK alone.
here in the UK alone. And it's almost like a market failure because from a business standpoint, healthcare is like it has like the biggest total addressable market, right? Like your TAM is basically humanity, because everyone's desire to be healthy is never going to go away. So there's so many players. I think there are 350,000 different health tech apps on the App Store right now. So, and with most of them just not having the best intentions, right? They're just trying to grab money. So yeah, I think it's almost a type of market failure, and where you unfortunately don't, because of all the white noise, you don't see the best players in terms of the ones that want the best for the patient at the end of the day reach the top. Yeah.
And I think that's actually a very short-sighted position that you see a lot of companies taking this view that, we're going to hyper segment, we're going to get our customers, and that's enough. But actually, if you took a view that you were actually just about patient value, and that's, I think almost fundamentally, I'm ethically as a physician obligated, in fact, to make things that only serve the patient ultimately, then actually there's a much bigger long-term value there. If you can demonstrate that your technology actually improves hard patient outcomes, that's hugely valuable to the patient, to the clinician, to the payer. Like it's kind of like a self-fulfilling value chain if you can demonstrate that what you're doing is actually a good thing. And I think too few companies, maybe it's a lack of capital or a lack of knowledge about the space, but they never actually make that leap into becoming a sort of real therapeutic in the way that you think of a therapeutic would require the standards for medicine. But I think digital has to move that way, because if it doesn't move that way, then this chaos will continue basically, and I don't think that's sustainable. And that's why we're trying to build a bit more.
Yeah, and I think part of this is you're trying to layer digital on top of a dysfunctional platform, being healthcare, right? Because healthcare in itself, we've mentioned it. It is highly fragmented. It is. So you're using digital to try to fix some of this, but it's the underlying cause needs to be addressed, right? when you look at this, how do you look at your product development as it relates to value-based care?
Yeah, that's interesting. Can you explain from a US perspective what you mean by value-based care? Because I think it means something very different here.
Okay, so for us, what value-based care means is there's basically three tenets to value-based care, right? Better outcomes, greater efficiencies, reduced costs. So if you can hit those three things, like that's the holy grail, right?
Yeah.
And everyone in the healthcare ecosystem, the payers, the providers, and the patients all want those three things, right? Very difficult to obtain, obviously, but if you can focus on value-based care, right, then it's almost a no-brainer to go to market.
Yeah, I mean, that's kind of exactly what I was saying. But it's interesting because, like, I don't think we use that phrase a lot in the UK because obviously we have essentially a nearly 95% publicly funded system. So if it's not those three things, you don't see it, right? It doesn't exist here. So we just call it care, right? Like it has to be effective, has to be cost effective, so we don't have, there's not much options. There's actually, I mean, and the flip side of that, there's not much patient choice, but these are I guess the differences between the systems.
I mean, those three tenets that you just alluded to, that's basically the immediate outcome of, for example, the AI Copilot prototype that we just developed, because that allows doctors to save 60% of time, which is initially taken up by administrative and clerical overhead on these EHR systems. So if you free up 60% of a doctor's time, then you effectively double their capacity for care then. So like Dom was saying earlier in the call, you can't, there's this huge global healthcare crisis, right? Because there's this overwhelming pressure being placed on limited clinical resources by the aging population and the recent pandemic. And you can't stop the aging population and you can't instantly train more human resources. But what you can do, which is what our solution tries to address with this AI Copilot, is you can effectively multiply the capacity of the existing clinical resources that we do have and make most out of that, which then results in better care and greater efficiencies and lower costs.
Yeah.
I
think
great, sorry.
I was just going to say that from an outcomes perspective, that's something that I've not really seen much and not enough of, especially in digital in general. And interestingly, before AI and before digital therapeutics and before smartphones, it was a question that we were asking when we introduced EHRs. And we were saying, where is the clinical benefit here? Like, we can see all these fictional benefits of tracking patients and data, but in reality, we didn't cost for any of the drag. So there is a lot of evidence to say that EHR use compared to paper takes about twice as long. So you've lost like half those patients. So how do we then build, in theory, the best of both worlds? And I've heard hospital administrators basically say, we're going to balance this on the backs of doctors. But if you think that the fundamental unit of the healthcare system is a clinician and a patient, and everything else is a derivative of that, then anything that is so impactful on that relationship can only be deleterious to the system as a whole. So I think that's kind of been something that I've always hated the electronic healthcare record system. I wrote a letter to Cerner like 6 years ago saying your system's slow and it takes ages. And now I finally get to like try and build a solution.
Did they respond?
No, but I think suspiciously they did sort of bring a few products out which look very like what I was suggesting they should build. But anyway, that's a lawsuit for the future. But obviously I'm joking. I'll take that out. But I think that is. And interesting, I was speaking to a colleague in Ireland, and a lot of the hospitals there have actually gone back to paper, weirdly, because they had a cyber attack. So that's a whole nother like vulnerability that we hadn't considered. But how much the doctors love paper compared to the old electronic system is really interesting, because tasks are instant. Write a prescription, write a letter, write a referral, done. And then there's nothing else. Obviously, from a wider ecosystem, there's a lot of problems with that. But from that fundamental unit, so can we, in fact, produce the instantaneousness of paper, the ease of accessibility for clinicians and patients, and still have some sort of way of tracking and keeping kind of metrics? And I think that's where AI can be a hugely powerful thing.
Yeah, I mean, obviously, paper is a very short-sighted solution because paper gets siloed, and therefore that data sits in a paper file, and if I go somewhere else, that paper file doesn't exist. I may request it, but then, your office will get around to my office, and, there's a considerable amount of time. And in most cases, you can't wait for the paper file, and we have to make decisions with limited information because, the data captured in the paper file is not readily available.
Yeah.
So I guess my biggest question for you guys is, and I very much, embrace and encourage your enthusiasm, but you're looking at a very highly fragmented market where a lot of these solutions exist, obviously not in one place, and we still have some of the, core problems within healthcare that haven't been resolved. So how do you, that feels like a headwind. How do you deal with that?
Yeah, I use it as a headwind. I just see it as like a really great mountain to try and climb, right? So first of all, if you subscribe to the thesis, which obviously everybody in a sort of VC startup mindset must subscribe to, that a startup could potentially grow big enough to address some of these problems. Well, the first thing I'd say is like, well, what would the ideal team for a health tech AI startup look like? Well, it would look like this, I would say. Hard to say any better. Here's an MD, loads of experience. He's one of the world's best AI engineers. So that in itself means that it's almost like, oh, this is a challenge, but we're the right team, and that makes it fun and exciting. But I think the other thing is like, if you can start disrupting from the ground up. So a lot of, as you sort of alluded to earlier, a lot of health tech companies, digital platforms are just trying to build on existing systems. But if you could start right from the beginning, like I've said this before, and I said this in one of the articles that you guys shared, which was really like great of you. If you took the resources that we have now in terms of technology, but also the lack of resources in terms of humans, and the patient load that we currently have, the complexity and the chronic, and you were to build a healthcare system from scratch, you would not build what we have right now, right? You would build something completely different. And I think that in of itself actually is what we are trying to do. We think that we're starting relatively small by augmenting various parts of the system, but ultimately this, the technology that we have in 10 years' time will massively change how healthcare is practiced, how patients access care, how clinicians treat patients. And we won't probably have a lot of the models of care that we currently look at. And that means that somebody's going to have to rebuild from scratch that future without having to tie into any incumbent system. And I think that's kind of the challenge, the excitement of this headwind. And then the other thing is like, and some of the solutions that we're building is basically building essentially a new market. This is like a new layer of healthcare, right? The digital therapeutics, AI enabled, connecting different aggregating. So there aren't many incumbents here in this particular substrata, I suppose, that we're trying to like build on top. And in that sense, actually, it might even be probably the solve for a lot of those issues that you've just said, interoperability being probably one of the biggest and most annoying issues, certainly from a physician point of view, and a patient point of view, actually. And that's actually, weirdly, in the US or Sweden or the UK or Australia, it seems to be almost a universal problem. And that's because a lot of the solutions were built with that sort of fractured, B2B SaaS enterprise sales kind of mindset. Whereas actually, if you start with a completely different mindset, we're going to build this big aggregating machine, and that's actually the business model, then you would build something very different. And I think that's actually potentially an answer to some of those big challenges.
And then how do you change the healthcare provider mindset? Because, we're in the tech space, we're all about let's use technology, let's, leverage technology. And yet, as you mentioned, the doctors are trying to go back to paper. They're going in the other direction. So, how, even if you develop this, and I have every reason to believe you will, how do you get the doctors to actually use it?
Yeah. Oh, is it for me? Oh, okay. Well,
yeah. Well, I don't care. Somebody asked
this question. Doctors are not, and I think I find this fascinating. I've been around technologists for like at least about the last year, and there's this like attitude that doctors are sort of very slow to uptake things. They're very intransigent. They don't like new things. None of that is actually true. I mean, from the evidence perspective, that's not true. But actually, what I want as a doctor is I want to be able to treat patients and have maximum impact for my time. I want to leverage my time to have maximum impact for my patients. So any tools that you give me that helps me speed along that process, I will adopt. And any tools that you give me that you think is good from a technology point of view, but impairs or impedes my ability to do that, I will reject. And too many healthcare providers don't actually make the decisions about the healthcare systems that they adopt. So, you've got administrators saying this is a great insurance tool, and you've got payers saying this is a great coding tool, but nobody's really going, but do doctors like this? Is it good? So what we're trying to build is things that genuinely delight clinicians. I want you as a clinician using stuff that we make to feel like you're a superhuman doctor. And actually, some of the prototypes that we've used, I actually felt like that. Like, I didn't touch the computer. I spoke to the patients. It felt like being back at medical school again, right? Like, you don't have any of the other paperwork and workflow in the way. It just feels like it should be. And if you take a real long bird's eye view of how medicine's been practiced for like 150 years or whatever, this weird time where we spend our whole time on the computers and we don't look at patients and there's no human-to-human interaction is going to look like a very odd window, I think. And before that, it was paper, and after that, it would be something much better. And I think the way to get around that is if you build something that clinicians really want and patients really want, and you meet those three tenets that you talked about, then everybody will adopt it. I think that's not going to really be a problem, but it's about fundamentally giving stuff that actually that patient-clinician interaction was on both sides. And selfishly is building stuff that I want, but I guess that's the fun of it, really.
But there's a fair amount of investment, whether it be a learning curve or what have you. There has to, it will take a little bit longer initially because you're learning the system, right? So they need to invest. People hate change, and then what the problem probably is that a lot of them don't get past the learning curve and like, oh, this takes too long, right? Because they're still in the learning curve. Versus, when I first started using any software, right? Initially, it takes me tremendously, long periods of time to accomplish anything. But 6 months down the road, I'm doing it automatically. It is part of the problem that they're not willing to or don't understand the learning curve when adopting new technologies.
Yeah.
About doctors adopting new technologies.
I mean, I could talk about this all day, but I'm interested to see what you think from a technology point of view.
I mean, it seems like they're already using, like the current EHRs that I've seen, like Epic and Cerner, like they have horrible user ergonomics and user interfaces. It's like they at least seem a lot more complicated to use than like the Microsoft Office suite, for example. But I mean, that's also part of the reason why we're building this AI copilot that sits literally on the desktop level and is able to use these softwares for them, right? Because in the limit, then all you really have to do is that you don't even have to, if like a new EHR comes out, you don't even have to learn to use it, because you just tell it to like pull up the information of some patient and it'll be able to navigate the specific new software for you.
Yeah,
get all of that for you.
So that learning curve will potentially be a problem that we eliminate as well.
Yeah, exactly. That's like the super long-term vision. And like,
but again, I suppose it's about having the mindset of a clinician. And I know what it's like when you're introduced to the new system and they're like, oh yeah, adopt this. I'm just like, no, I've got patients to see, I'm busy. Like, that's it. Like, it's not me being selfish. It's like, I've got other priorities. So we would basically—
But you jumped to that mindset without even having tried the system, right?
Yeah, and I think that's actually that's a function of burnout. So you don't have capacity or patience, especially if you're extremely busy. I mean, I'm talking from past experience. Like right now, I'm in a tech startup. I'm not in the clinical workflow like I used to be, but my wife's still working. She's doing 12-hour shifts, and I know what it's like. Like anything that's an impediment to your workflow becomes a frustration. And actually, if that frustration then leads to patient harm, it becomes what we call moral injury. So you're actually injured by how terrible your IT systems are. And I think that is actually something that we have, there's a term for in the US, which is EHR burnout. And it's this idea that we're giving clinicians tools which aren't fit for purpose, which actually stop them doing their job, but their job is to save lives. So if you stop someone from saving a life when they otherwise could, that is extremely harmful to their soul. And that's what the idea of moral injury— I mean, it sounds very grandiose, but that is what moral injury is. So then if you put something else in front of them and you're like, oh yeah, use this system without any sort of, means or accessibility. But what's really interesting is that doesn't have to be the norm. If you were building for the user experience and not for the coding or insurance tools or whatever the system is actually for, you would build something different. And if you look basically at like Apple, like my 2-year-old can use my iPhone pretty well. Right? There's no learning curve. She navigates, she does the educational tool, she finds her game, she plays the thing. So why can't we build that for clinicians? Why can't we keep it as simple as possible? Because ultimately, I've said this before, and it's a pretty controversial statement, but a lot of electronic healthcare records, they only need you to be able to write stuff down and then read it later. And that's it. Like, there doesn't need to be all these other features. Some of them are useful, some of them aren't, but that is the fundamental requirement of it. And if you could massively improve that, either through better EHR systems, which I don't want to touch, no, thank you, or what we're trying to do, which is basically build an interface which is much simpler and much easier to use for any system, then actually you would alleviate a lot of the clinician pain. And I think no system or people are really focused on clinician pain, but you make better clinicians, they give better care, patients are happier. And I actually think that's a niche in the market that people haven't focused enough on really.
But, but the bottom line also is somebody who has to pay for it. So you have to get either the payer on board or the healthcare system on board, because just because the clinicians like it doesn't mean anyone's willing to pay for it. Right. So you have to demonstrate.
But if the clinicians were seeing twice the patients a day,
Okay.
I don't think you'd have any problem paying for it, right? I mean, that's kind of the idea. And the clinicians were happy to see, I'll give you a really good example. When I first started running cardiology as I guess a senior resident would be the equivalent in the US. So relative seniority, wandering around on my own. I didn't have a login to the computer for like 3 months. And it was great because I had a junior intern equivalent to come with me. But the thing is, my capacity to see patients was doubled. I literally saw about 35 patients a day in terms of referrals. And that was like an insane amount. So I actually think that there is a win-win. Doctors don't shy away from hard work, but they do shy away from pointless work. And if we can, rebalance that even a little bit, then I think everybody in the system wins. And the same thing on the patient side as well.
So let's shift the conversation a little bit. Where are you guys as far as product development, and what are some of your milestones that you're looking at?
Yeah, so I think this is where we're super early, so we might have to keep pretty stum here. But
Okay.
We've built we're focusing on the clinician side to start with. I think we're happy to say that. And as Chris has sort of said, we're building an AI system that can basically be like a co-pilot for a doctor. So I think the best way to think of it is
it's like that story that you just told.
Yeah, exactly. Well, there's two of you, right? There's somebody sees the patients and does all the fun stuff, and then we clone you digitally and they do all the boring stuff. And that's kind of the idea. And we've built some prototypes, and then we're basically sort of testing some of our ideas locally in the UK, and then we'll be building into some bigger and better things early next year.
And then how did you guys end up in Entrepreneur First?
So I actually found out about EF through some professors I was working with, and also some VCs from my previous companies. And I just thought it was such an interesting thesis that you can, their founding thesis is that you can bring together strangers and turn them into co-founders of really meaningful companies. And my thinking was that after I left uni, I was deciding what to do with my life. I realized that I was living in a very limited window of time of risk tolerance, where right now I'm just responsible for myself and no one else, right? But that's not gonna always be the case. So why not do the craziest, most risky things, because now I can fail. So that was sort of my thinking.
Yeah. And I'm laughing because I hate that answer, because I've got 3 kids and
and you're making your wife work 12 hours a day, so yeah.
I need to exit and go look after my children. So yeah, that's really funny. So I come in from almost the complete opposite. So basically, I'm looking to so I actually think I came to EF because my risk was basically staying in the system and not doing anything impactful other than seeing a patient after patient for the rest of my life. But what was really interesting to me about Entrepreneur First is that they were looking for people that were naturally disruptive, always restless, looking at new ideas. And these were things that I always thought were bad, because I was in a very, in the hospital system as a clinician, and this is probably why there aren't that many clinician innovators. They're very much, it's a team sport, it's very high risk. You can't just be coming up with new ideas and doing X, Y, and Z, and that became very disruptive. So for me, it was finding, actually, this is a normal trait. I was just in the wrong place. And now I feel like I'm in the right place, which is super interesting. But again, it's about impact, and things move, even, you know, and I will take that criticism as a profession. Medicine does move very slowly, for lots of different reasons. But I think some of that can be the lack of the people who should be making the decisions are just inundated, right? They just can't, they don't have the capacity. So coming out of the system and finding somewhere where it's like, okay, you can do what you want, have at it. And actually, you know, these are all people that are wanting to do exactly what you want to do at the same time is hugely powerful. And that's where, you know, me and Chris really sort of met on this, like this mutual love of unleashing the power of AI in healthcare. Because, you know, it's such a sort of wild west in a way. But I think potentially is well, I don't even think potentially, I don't think it's arguable. I think it is the future. And now the question is like, who is going to make that future? And that's why we're sort of making a company.
So I realize you guys are very early on your journey. If people want to follow what you're doing, and where should they find you?
Yeah, that's a really good question.
Twitter.
They don't follow my Twitter. I mean, so I think what we're probably doing the next sort of like, in fact, maybe like tonight or something, we'll set up a LinkedIn page so we can put some details on there, and we'll get our website live and things so people can follow what we're up to. And you know, and my blog on my LinkedIn as well is where we'll be blogging a lot of the journey. So I've blogged a little bit about, you know, learning the CEO stuff, and then periodically about some of the observations about habits and digital therapies and things like that. So we'll be putting a lot more content on there as well. And then early next year we'll be out in a big way, I would hope, in trying to expand and doing and getting into the market properly.
So what you do is you'll send me some of those links to your blog and those various social media platforms. We'll include them below, so folks who are interested in following their story and following your story can check out below those links. Gentlemen, we very much appreciate your time. Sounds like you got a lot of work ahead of you. We'd love to check back in 6 months to a year and see where you're at.
Yeah, all right, well, fantastic.
Thanks, Mike. Enjoy speaking with you.
Yeah,
Thanks,
likewise.
guys. We
Thank you so
appreciate it.
much.